Welcome back after the break. I hope you all refreshed yourselves. We're now going to move on to session 2, where we're going to look at the impact of stigma on U equals U again, but this time looking at provider and policymakers. And our first speaker is from Thailand, from APCOM in Thailand, Inad Rendon, who's going to speak about stigma and art uptake and retention in Asia Pacific. Inad identifies himself as a gay man openly living with HIV, and he oversees and provides strategic direction to APCON's portfolio within the programme's unit, looking at many areas, including research, demand generation, behavioural change, capacity building and technical assistance, amongst others. Inad, it's a great pleasure to have you here today.
I'm going to tell you a story. I am from the Philippines, a self-identified gay man, and don't tell this to anyone, but I'm a person living with HIV. With undetectable viral load. I learned about my HIV status last 2009, and I started taking my ARV last 2011. Take a guess who were there with me when I found out my status. My mom and my dad. My parents were there when I received the news. My dad was there when I took my first ARV, the tenofovir, lamivudine, and nevirapine. I was also in law school back then, and back then, 2009, I cannot say that there was not really a lot of HIV information. When I told my friends in law school, I cannot say that there was no judgment. There was little judgment, but they did open their minds and they did their own research about HIV. Up until now, we are still very close friends. I moved here to Bangkok in 2013 to start my work with APCOM. And since then, there is this infectious disease specialist that I always consult with. She's very motherly, and I love speaking with her that I am one of her clients who spend most time in her clinic than anyone else. So I visited her clinic last week, and when I entered her clinic, she displayed this very serious face, and she threw me a question right before I took my seat. She asked me, "So when are you bringing U equals U in Asia?" And I was like, aren't you supposed to ask how am I first? And then she was like, "You're okay, but I know some other people are not okay. So when are you bringing U equals U in Asia?" And this is the kind of doctor who go to AIDS conferences, and she's also the kind of doctor who I sit in sessions during those conferences. So I say that I'm privileged. So when people ask me, what is my secret for being always adherent with my treatment and for always being accessing ART all the time? And I say that the secret does not lie with me. The secret lies with the environment that surrounds me. I have a very supportive parents, although they have a lot of questions and confusion during the time that they find out that I'm HIV positive, but they took the time and effort to learn more about HIV. I have very open-minded friends, and I have a doctor whom I can tell everything, almost everything, and does not put judgment on me. And now I guess that is very important for people living with HIV who has experienced denial, grief, or unacceptance of oneself. And those are the very important factors when accessing ART and making sure that that person is adherent. Antiretroviral therapy saves people living with HIV's lives. It is very effective to suppress the virus. And when the HIV virus is suppressed, we can avoid a lot of opportunistic infections that can cause more problems to a person's health. The WHO recommends ART for all people living with HIV as soon as possible. It doesn't need to have a particular number of CD4, but we are pushing for early treatment because early treatment will prevent the spread of HIV. For ART or the antiretroviral therapy, the evidence is strong and clear. The data shows that the effectiveness for ART with viral suppression is estimated to be 100% for preventing sexual transmission of HIV to people living with HIV sexual partners, and that is from the US Center for we have released a survey with our partners and our partners at the country level, and also the health service providers that we work with at the different levels at the country. For the community, we ask whether they are aware of antiretroviral therapy, and the answer that they gave us is that yes, they are aware of the ART, and most of them are taking it. And they're also saying that there are still some challenges from them on their side in order to be adherent. For example, remembering to take the pills on time, or remembering to take the pills on a particular day. And from the health service perspective, we asked them about whether or not people are aware of ART and what do they think are the challenges in terms of the people living with HIV accessing ART. Most people responded that they are aware of the ART, but found that some people are not accessing or have challenges accessing ART because of stigma in the healthcare setting. And this stigma is preventing them from getting adherent to ART, and the case management is difficult because of the stigma that is ever present in healthcare facility. So from this alone, we can say that stigma, especially from healthcare providers, are posing or is posing a challenge, or is posing as a barrier for people living with HIV to access the services. From my experience in the Philippines, from the time where there is less knowledge on HIV, the stigma has actually prompted me to move to Bangkok so that I can access I can access ART more freely without fear of these people knowing who I am. And the learning that I have is that the environment, which is very supportive, non-stigmatizing, and non-judgmental, can actually help a person living with HIV to access services more freely, to be adherent, because they have an environment that supports who they are, and they have especially if they have a doctor or a medical professional who they go to, this person will actually manifest or display that their lives are more important than the judgment towards their person. So if we are going to end or achieve epidemic control in HIV, first we must address the stigma and the discrimination that is still apparent in our community, to make sure that the people living with HIV are accessing the treatment regularly. That's all from me, and thank you very much.
That's great to hear that point of view. And now we're going to move on to hear a different point of view. It's now my pleasure to introduce Dr. Wong Chen Song from Singapore, who's going to give us the clinician's view on the impact of stigma. Dr. Wong Chen Song is a consultant physician at the Department of Infectious Disease at Tan Tock Seng Hospital, and also works at the National Centre for Infectious Diseases, where he is head of the clinical HIV program.
Right, so I'm here today to really talk about the role of the clinician in terms of reducing the stigma experienced by people living with HIV, with a bit of a focus on how we can use that to further the aims of U equals to U. So first of all, I really want to start by talking about how I have experienced, as a clinician, as a physician, HIV stigma. Now, I'm not someone who's living with HIV myself, but I've been involved in caring for and providing, clinical care for people living with HIV for a number of years now. And I think over this time, I've actually had several close brushes with HIV-associated stigma. The first one is really in terms of providing medical care. Sometimes some of my patients may actually have been denied certain dental, surgical, or other medical services on the sole basis of their HIV zero status. And this is, of course, greatly upsetting to me. And we've often had to engage these other providers and explain to them that people living with HIV, especially if they've got virally suppressed situations, don't actually pose any health to these providers. Sometimes, however, and perhaps even more frustratingly or sadly, is that our people living with HIV, my patients, because they anticipate that they might experience some stigma or discrimination, don't come forward and seek help for medical problems that they might have. Apart from this, my patients may also tell me stories of the stigma that they experience outside of the medical field, the stigma and discrimination that they feel at home, at work, and in school sometimes even. And these stories of being called names or being shunned, being thrown out of their homes are unfortunately all too common. And they tell me as their physician, sometimes hoping that I can help them in some way. Another way that I've experienced HIV stigma is sometimes the discrimination and stigma that I feel as a HIV clinician myself, where it's often a situation where my colleagues may view me as being a lot of, or very much of an advocate or an activist for my patients, because we've had a history of fighting for the best interests of our patients. Sometimes not understanding that people living with HIV are already so marginalized that what we are doing is just trying to fight for them to be accorded the bare minimum of dignity that people of other medical conditions already enjoy as a privilege. And the last way in which sometimes I feel HIV stigma can be experienced as clinicians is where HIV knowledge, the science, doesn't always get translated into HIV practice at perhaps a policy level or an institutional level. And this is really where we see the practice gap between the really strong evidence we have for U equals to U and treatment as prevention, and yet sometimes there's that gap between policy for universal access to antiretroviral therapy or subsidies or financial aid for people who may need treatment. So I really want to talk about how the clinician can work and strive to reduce HIV stigma. And I'm going to propose that as clinicians, we can do so in one of 4 different ways: as practitioners, as advocates, as educators, and as researchers. So first of all, I think, I'm here to speak as a clinician, and many of us who are medically trained, we identify first and foremost as practitioners, as physicians, as doctors. I think the most important way and perhaps the most effective way of being able to reduce stigma in this role is just by being mindful of who we are, the roles that we play in the lives of our patients, of being mindful that we need to be evidence-based in our prescribing and in terms of providing clinical care, something I think most of us take for granted and do almost instinctively, but being mindful that there is good evidence out there to say that U equals to U holds true and can help in terms of reducing the stigma experienced by our patients. Secondly, in terms of being patient-centered, patient-focused in the care that we provide and transforming the entire HIV care continuum and ecosystem all the way from waiting room to home. And we can do that in our role as clinicians by ensuring that the practices, the settings in which we provide care, everyone in that link, in that ecosystem are trained the same way, they know the same science, and they know the same methods in which to speak to our patients, to treat our patients, and interact with our patients to reduce any stigma that our patients may have felt in the past before. Of course, as doctors, it's also important that we tell our patients about U equals to U. We tell our patients that they are not able to transmit the virus if they're on treatment and have viral suppression, something that we may take for granted, but it's important to tell people living with HIV that we see in our practice and in the course of our work. Now, next is as clinicians being advocates. And this is where I feel, as doctors, as physicians, we are in an ideal position to advocate for and to rally for our patients. We have a privileged position as professionals, as experts, and as prescribers. And hence, we really should be leveraging on this privileged position to do all that we can. We have a unique long-term relationship with our patients. It usually starts off as a physician-patient relationship, but in my own experience, it can often develop into something that's deep, that's meaningful. Our patients, for many of my patients, I'm the only one who's aware of their HIV diagnosis, and I hope to continue to grow and develop that trust and rapport that I have with these patients. As clinicians and as content experts and as key opinion leaders, we often have an influence on policy at various scales, either just as doctors, as prescribers, but also sitting on committees, sitting on advisory boards. And in all of these roles, I think we have to bring in our professional position and argue and fight for the best interests of our patients, including reducing the stigma and discrimination that they may face. A clinician as an educator is something that I feel particularly strongly about, because I'm also actively involved in training, young doctors all the way from medical school to postgraduate and infectious disease and HIV training. And I feel that because medicine remains essentially at its core an apprenticeship, we impart not only just medical knowledge, we also impart attitudes, we impart values, and we role model behavior for those that we train and those that we teach. And so I think as doctors, we have to try and make sure that we design HIV education with stigma reduction at the forefront, having it in mind, putting it into the DNA of our syllabus, our curriculums, and in teaching about HIV. I want HIV, and I feel that HIV should be incorporated into medical education, not only at undergraduate level, but at postgraduate level, even for people, even for trainees, or even for medical specialties where HIV is not at its core. So traditionally, not necessarily just in terms of genitourinary medicine or infectious diseases, but in internal medicine as a whole. And in doing so, we need to also include and incorporate concepts of treatment as prevention and U equals to U, all the way from the virology and the microbiology of it to this clinical management, and even using HIV as a hub for teaching clinical communications, for teaching medical legal ethics, for teaching public health, caring for underserved populations, gender and sexuality studies, and so on. So in short, using HIV and taking HIV to be a central nexus for clinical education and teaching people about reducing stigma at the same time. Last of all, it's about being a researcher as a clinician as well. So HIV stigma and how to combat it must be vigorously and rigorously studied as an important topic in HIV research. It must be researched from the point of view of stigma reduction from the points of providers as well as patients alike. We need to study the determinants of stigma and what interventions work best in reducing stigma. We must prioritize implementation science research looking at U equals to U, and to bridge that gap that I talked about just now between the science of it and its implementation and interventions. And we must continue to advocate for the involvement of people living with HIV in clinician and investigator-initiated clinical research alike. This is something that we as clinician researchers are in a unique position to be able to do. So in these four roles, I believe the clinician is in a great position to reduce HIV stigma and to push for U equals to U in this exciting future that we are on the cusp of. Thank you very much.
Thank you for that great presentation. And so we're going to move on to the next speaker, who's Dr. Foy, Dr. Do Hoi Foy, who will talk about the perspectives of the policymaker. So we've heard, if you like, from the patient representative, we've heard now from the clinician, and now we're going to hear from the policymaker. And Dr. Foy has a great deal of experience. He's worked in the Vietnam administration for HIV AIDS control within the Ministry of Health of Vietnam for more than 15 years, and is actively involved in the field of HIV-related stigma, and runs, indeed, stigma and discrimination programs within this institution.
I would like to thank the organizers for inviting me to talk about the respective policy maker on stigma and U equals U. Before talking about this topic, I would like to share about the HIV situation in Vietnam. You can see on the slide, now Vietnam has about more than 250,000 people living with HIV in community, but there are about more than 210,000 cases reported. The cumulative number of deaths are almost 110,000 people. The trend of HIV epidemic has been reducing since 2008 in three categories. The first one is the number of new cases reported. The second one is the number of deaths, and the third one is the number of deaths. In the map, we can see the epidemic is more burdened in the north and the south of Vietnam. How about Cascade and target 1990 in Vietnam? We can see on this line, by mid-year of 2020, Vietnam achieved 85% for the first 90. For the second 90, we achieved about 75%. For the third 90, we achieved more than 55%, if counting viral load suppression under 1,000 cells. Regarding stigma and discrimination in healthcare setting, the recent data we just conducted survey in three provinces, Bình Dương province, Hanoi city, and the Thái Nguyên province. Thái Nguyên province is in the north of Vietnam, Bình Dương province in the south of Vietnam. It shows that more than 90% of healthcare workers reporting fear of infection when drawing patient blood. More than 20 of healthcare workers reporting fear of infection when touching patient belonging or clothes. There was about 15% to 38% of them use unnecessary protection when caring for people living with HIV. When we ask healthcare workers to know their opinion about people living with HIV, almost of them agree that people living with HIV should be allowed to have a baby if they wish. It means there was about 5 to 10% of them do not agree with this opinion. Around 20% of them believe that people have HIV because they invest in irresponsible or immoral behavior, or they do not care that they could infect other people. In this survey, we also asked client experience. Almost of them have positive experience in terms of procedure required to receive service at health care facility, and they feel safe and comfortable to share information on health and related behavior to healthcare workers. Client also had positive answer in terms of welcoming, friendly, treat respectfully, privacy, and confidentially decision-making involvement. Now I would like to share about our perspective on stigma and discrimination and yêu của you in Vietnam. In Vietnamese, yêu của you means không phát hiện bằng không lây truyền. We also call cây yêu của cây. With support from US CDC, Vietnam knew this message quite early. As we know, you message is important in HIV program. So we decided to do campaign You in Vietnam. One purpose of You campaign is to remove three pillars of HIV stigma. The first one is the stigma in how the infection was required. The second one is HIV as a terminal illness. The third one, chronic infection signify chronic infectiousness. We also understand that you contribute to target 1990. In this slide, you can see two opposite posters. The first poster developed more than 10 years ago means F equal to death. The other picture in this time means the HIV people, infected people can live, they can laugh as other people. Now we always use a positive message for people living with HIV. So that U equal to message integrate in the guideline for HIV treatment and care in 2017. It is issued by Ministry of Health. In 2017, Vietnam started to implement EU activity. In this slide, you can see we organize a talk show in VTV. Vietnam also issues a national guideline on implementing EU campaign for province. Vietnam officially launched the national campaign on EU in October last year. Many other activities on EU have done so far, like we organize workshops, we organize training course for healthcare workers, we also organize a training course for journalists, for community leaders, for network leaders like BNP Plus, SecWork, MSM, IDU, TG. We also organize talk shows. We also develop posters, lab lists on EU. We also have 2 websites and fan pages on EU. We also integrate EU message in the 1 Day campaign last year. After that, based on the guideline from central level, many provinces also organize EU campaign. Vietnam achieved 10-fold increase in viral testing in 5 quarters with high suppression rates. We think one of success factor is to create patient demand. They want to know if they got EU after treatment. However, the recent survey also shows that Vietnam has both percentage of clients have viral test and viral suppression are very high, but percentage of clients who know their viral results is still low. I think we should improve this issue both for healthcare workers and people living with HIV next time. That's all for my presentation. Thank you for your attention.